So our nursing title, this is where we have identified our problem. So we have clustered our data and we have come up with at least one of their main problems. We give it a name, and then if needed, we add any adjectives that will help describe it. So an example of that would be the difference between constipation and perceived constipation. Constipation is actually by Nanda. I guess that's on the next slide. Let me go to the next slide, and then I'll tell you what it is. So constipation, as described by Nanda, is a decrease in normal frequency of defecation accompanied by difficult or incomplete passage of stool or the passage of excessively hard and dry stool. When we look at perceived constipation, this is a self-diagnosis of constipation and the abuse of laxatives, enemas, and or suppositories to ensure daily bowel movement. So any of you that work in the medical field may know that some of our elderly become very bowel fixated. I mean, they would like to go at least once a day. Some of them like to go out every time they eat. Some of them want to go in the morning and in the evening. And they will come and ask for medication to fix that. They will ask for milk and magnesia. They will ask for a suppository. They will take lactulose. They will take anything they think will make them go, which is where we get to perceived constipation. Because if you're going every day and you're actually having a regular soft form bowel movement, you are not constipated. But some of these patients feel that they are. And if you look at what they're eating, they maybe shouldn't even go every day. They're not really eating enough substance to go every day. Maybe every other day, but maybe not every day. But a lot of our elderly become very bowel fixated. So that's where we end up with perceived constipation, because it's a self-diagnosis. So our title or label needs to be clearer, precise description of our problem. And that helps you differentiate between two similar diagnoses, such as constipation and perceived constipation. When we look at our contributing factors or risk factors, these are conditions that might be involved. So these may become our focus of our nursing intervention. So we have our title, then it will say related to, or just RT, which stands for related to, and tell you why. So the example here says impaired skin integrity related to immobility. So we have the impaired skin integrity, and the why is because you're immobile. So if you're not up and moving, you're laying in bed all the time, it's going to cause your impaired skin integrity. So when we're looking at the related to, this is what's causing the problem. And when we look at our defining characteristics, these are our clinical signs and symptoms that the problem exists. So I'm going to apologize because back when this slide was written, it was written as evidenced by your book, and we now teach as manifested by. When you guys are tested, it will tell you as manifested by. You may still see though, depending on your clinical setting and what kind of care plans they use, it will say as evidenced by. They mean about the same thing, but your book and all of your testing, it will have the title related to and as manifested by. The as manifested by is the signs and symptoms. So how can you prove that that problem exists? So the example here says impaired skin integrity. And we have the related to the immobility. So because they're not moving. And it says as evidenced by, and we have the wound. We have a 1x3x1 open area on the coccyx. This is how we know that they have impaired skin integrity. This is our proof. So if you say impaired skin integrity and your defining characteristics are a red area on their coccyx, you may not have the proof yet, because a red area, unless it is a stage 1, which means it does not blanch anymore, is not really open skin. It's a stage 1 is non-blanchable, so it would be a stage 1 pressure. But if it's just red, kind of like if you cross your legs, you lay on something too long, you get that like red mark, but it goes away. Sometimes the same thing will happen with our patients. Okay, we're going to talk about the 4 types of nursing diagnoses. I will tell you for the most part, and the next 2 slides that we talk about are actually our actual and our risk. Those are the ones we use the most. Syndrome and wellness. I may have used wellness while I was in nursing school having to write a care plan. I've never used wellness actually in nursing. I mean, I worked in a hospital. None of my patients were well. They don't come to the hospital because they feel great. I was looking at actual problems. The wellness and risk would be more of like maybe community nursing, stuff that you're doing out in the community to make sure that they stay okay. Your syndrome is more of like trauma. So when we look at syndrome, because we're gonna, the next few slides talk about actual and risk, so we're gonna talk about syndrome and wellness right now. When we look at syndrome, it looks at a cluster of problems. So your patient who was in a motor vehicle accident, a severe motor vehicle accident. So they may have, instead of having multiple diagnoses, the ICU may group all their diagnoses into a post-trauma syndrome and then list interventions to get that patient back to wellness. Because when you think about it, depending on what's going on with your patient, a lot of the interventions may be the same for each problem. So they group it all together and come up with a list of interventions. That would be a syndrome. When we look at our wellness diagnoses, these are our patients who are ready for maybe teaching or ready to improve their overall health. So this is where we're looking at readiness for enhancement, readiness for decision making, and how we would help support that information for that. When we look at our actual diagnosis, this represents a condition that is currently present with your patient. Your assessment of your patient indicates the problem exists. So during your assessment, you have figured out what they're related to, and you have the signs and symptoms of your nursing problem. It's usually written as a 3-part statement. So we have the label with definition if needed. We have our contributing factors, which are related to, and we have specific signs and symptoms from your patient's assessments, which are written as manifested by. So when we look at our actual nursing diagnosis, we need those 3 parts. We need a title, related to, and as manifested by. Your at-risk diagnoses, these are something that because of what's going on with your patient, because of what you have found in assessment, could possibly happen to your patient. At-risk diagnoses are written in only 2 parts. There is a nursing diagnosis label, and then the risk factors. Because remember, this is not something that actually happened yet with your patient. So this is because of whatever is going on, this could possibly happen. So this is just a title and a related to. So the example here says risk for impaired skin integrity related to mechanical forces such as pressure and shearing forces. So from your assessment, you are saying that this patient could possibly have impaired skin integrity from either laying, so pressure, not moving, or from mechanical forces such as shearing. So if you were trying to move the patient by yourself and you are dragging and lifting and you're shearing that skin, sometimes that could be more dangerous than letting the patient lay there. or if you're using a mechanical lift and that the Fourier pad is shearing their skin back and forth and it's not on correctly. So we're looking at, because of those factors, your patient could end up with skin integrity problems. So we don't have a manifested by because this problem does not exist yet. At this point, your patient's skin's intact. So you want to keep it that way. So your nursing interventions would be interventions that would keep your patient's skin intact. So it would be like, to get help moving your patient, to make sure they're properly positioned. When we look at outcomes, so these are our goals. This is what we want to see happen with our patient. Our outcomes or goals are patient-directed. They are patient-specific. So if you guys see a question on Wednesday that says an outcome statement, and it says the nurse as the first part of it, it is wrong. Your outcome statement must say the patient. So you look at your diagnosis and you see what you want to, what you would like to see happen. Depending on how alert your patient is, your patient may be part of this decision making. What do they want to see happen? And then you express it as an outcome statement. So your outcome statements serve two purposes. They help select nursing interventions. And they also establish how we measure how effective our interventions are. So we'll go back to look at evaluation. So if you say your patient will have intact skin in 3 weeks, you now have a time frame of when to go back and look at to see how effective your interventions were. Your outcome statements must have specific parts. There we go. Your outcome statements or goal statements must say the patient. They may say the resident, but they will always, we're looking at resident patient, we're looking at not the nurse. They must have a measurable verb. It should be specific and realistic to your patient. So if your patient is totally confused, can't tell you their name, a goal for them would not be that by the end of the week they will identify ways to have a better nutritional intake. That's not going to happen. That's not realistic for your patient. And it must have a time frame. Without a time frame, you never know when to go back and reevaluate. So you'll never know how effective your interventions are. So a complete outcome statement will say the patient. It will have a measurable verb that is specific and realistic to your patient, and it will have a time frame. So I think the example on your homework was about a soft form bowel. Your patient will have a soft form bowel movement within so many days or weeks of interventions being put in place. So we had the patient, we had a verb that was specific and realistic, and we had a time frame. If you don't have those 3 areas for an outcome statement, it's not a completely written outcome statement. So for impaired skin and skin integrity, with the ulcer that we had, an outcome could be patient will have intact skin within 3 weeks of intervention. So we have the patient, we have intact skin, and we have a time frame of 3 weeks, which is realistic. If you were putting goals into place to improve that 1 by 3 by 1 opening, 3 weeks could possibly fix that if you are doing all your interventions. So when we're looking at planning, we're looking at coming up with interventions now. So our interventions are activities that promote the achievement of our outcome or our goal. The activities that we select or the interventions that we select should be focused on resolving our problem. They should be monitoring the development of any new risk or any existing risk. And they may be interventions that carry out physician's orders. So for our patient with that wound, our intervention may be, if the doctor has an order that the wound should be, the dressing should be changed twice a day, an intervention may be that the nurse will change the dressing twice a day as prescribed by a physician. Because you still need a physician's order for wound management, but that can, you can make it into a nursing intervention that you will do it. There are two types of interventions. There are your physician prescribed interventions and your nurse prescribed interventions. When we look at physician prescribed interventions, these are interventions for pain medication, for Tylenol for fever. So these are all things that you get from a doctor. These are your wound dressings. So there are interventions you get from your doctor, but I will tell you right now, none of your doctors are coming to hand out a Tylenol to the patient. None of your doctors are coming to change wounds unless it's a very complex wound and they want to see how it's healing. So those are things they would write orders for you to do, but as a nurse, you need to do that. So they would go under your nursing intervention for that patient. Your nurse prescribed interventions are things that a nurse can do independently. So you don't need an order to turn a patient every 2 hours. You don't need an order to walk a patient unless they are non-weight bearing when you first meet them. You don't need an order to transfer a patient. These are all things that as a nurse, you can use your nursing judgment and go in and do with your patient. You don't need an order, or no one needs to tell you that when you are feeding a patient, they should be at almost a 90-degree angle so they don't choke. So these are things that as a nurse, you can just go in and do with your patient. If your patient's at risk for aspiration, sitting them up in bed and making sure they have cleared their mouth of previous food before you give more food, you don't need a doctor's intervention for. These are things that as a nurse you can do, or you could instruct your nursing assistant to do. So when we're looking at nursing orders, your nursing orders should contain specific information and instructional statements. Nursing orders should have a date. They should have a signature of the nurse responsible for the plan of care. So when the nursing care plan is written out, they will be dated, and normally the RN will sign it once they finish writing the care plan. It should have a subject of who will carry out your activity. So is this something that you as the nurse must do? Or is this something that your nursing assistant can do? So it should say who's able to do your activity you want to do with your patient. It should have an action verb, and it should have qualifying details. So what else do you want done? How often do you want it done? When do you want it done? Nursing orders do not need a doctor's order. They are something that a nurse can do independently. When we look at communicating a care plan, so we have, written nursing care plan is a product of our nursing process. So we've gone through our nursing process, we've assessed, we've planned, we've come up with outcome statements, we've put everything together on a piece of paper. It's important to have written guidelines because it promotes the continuity of patient care. So what I'm doing today, you should be able to come in tomorrow, and you may not do it the exact same way I do it, but you have the care plan, you know what we're supposed to be doing for this patient, you will carry out the same interventions for this patient. And then when I come back the next day, I will carry out those same interventions myself. So it's a continuity, even if it's not the same person every day with that patient, it's a continuity of the same interventions and the same care being given. You will notice once you go into clinical settings that each clinical and each facility uses their own format. Some still write all their care plans out on paper during care conferences, and they can be a little difficult to read depending on the handwriting. Some use computerized ones where it has like all kinds of interventions, but they only put a check mark by the ones they want to use, and you have to go through like 25 pages to find which nursing problems and interventions they're using. Some use computerized ones that allow them only to pick the problems and interventions for that patient, and they're much shorter. But they should all be individualized. Your entire nursing home should not have the same care plan, unless you're in a specialized floor Like unless you're on like a traumatic brain injury floor, unless you're on a specific floor, your entire floor should not have the same care plan. They should be individualized for that patient. Now, when we're looking at implementation, implementation is the nurse doing something. So this is you actually putting into process your nursing intervention. So this is an action by the nurse. So if there's a question that asks you about implementation, we are looking at the nurse doing something. So these are ongoing activities. You may be collecting data through your entire nursing process. So you do an intervention, and how did it work? Did it work? Did it not work? Could the intervention have been done better? You're looking at prioritizing your interventions. So what might have been most important yesterday may not be most important today in nursing interventions. You may need to switch things up if they're getting better or getting worse. Also looking at prioritizing throughout the day. So maybe at 8 a.m. when you got there, your patient was great, and you didn't need to do a them, but then maybe something happened. Maybe they aspirated during breakfast, and now there's, you have to reprioritize your intervention. What are you going to really do first now? Like I said, this is carrying out your nursing interventions and documentation. So documentation is a very vital component of everything that we do, because if it's not documented, it was not done. So if you've done, you were doing impaired skin integrity, and you said you were going to turn your patient every 2 hours, and you know that you and your nursing assistant turned that patient every 2 hours, but no one ever documented it, and the patient's skin actually got worse, it looks like you just left your patient. If you know you were, you're at risk for aspiration, and now your patient is aspirated, and you never put in that you sat your patient up and you made sure their mouth was clear, you made sure they can swallow secretions before you started feeding, it looks like you didn't do any of that. Documentation, if it's not there, it wasn't done. So please don't document before your shift starts or at the beginning of your shift, because you don't know how your shift's going to go. Document as soon as possible after an intervention. And if you do get to the point where you don't have time to document every intervention as you go, you should be keeping some kind of track on your report sheet of what time you did things, so that when you do have a few moments, you can sit down and put in information into your computer or onto your paper charts. When we look at evaluation, this is to determine the extent to which the outcome has been achieved. So you go back and you look at your goals. You're going to reassess your data and see if you actually met your goals. The actual response to your interventions is what you thought it would be. So you're going to compare your actual outcome with the desired outcome. Your possible outcomes would be that your outcome was achieved. So your patient's skin is better. Your patient didn't aspirate. Your outcome was not achieved. So maybe their skin got worse, so they did aspirate even with interventions in place. Or your outcome was partially achieved. If you look at a partially achieved outcome, it may be that your goal wasn't very realistic to begin with. So depending on the size of your wound and your patient's nutritional intake, maybe saying their skin would be totally intact within 3 weeks was not realistic. Some patients never fully get rid of wounds. Some may just get better. So we need to make sure that when we go back and look at this, was our goal truly realistic to begin with? During our evaluation stage is when we go back and change our plan of care. So if we need to, if our goals were met, we may need a nursing problem. If our goals were not met at all, we need to see how realistic they were and what else we can do to make them better. And if they were partially achieved, we may still need to rewrite our goals and add more interventions or change interventions. I'm going to show you guys these. We don't use these anymore. But these are types of nursing care plans that you may see. It has a place for data collection here, subjective and objective data. Remember, if your patient's not talking or confused, there might not be subjective data, but there should always be something that you can measure as a nurse. There's a goal. There's nursing interventions listed in priority, and then the rationale for these interventions. So why do you do them? Yes.
You have all this, is that in the back of the charts, or do they print them chart for a certain area they have it?
It depends on where you are. If they are computerized, this all may be in the computer. If they are still computer and paper, this may end up in the chart somewhere. We went to halfway through last term, we changed to concept mapping. Some of us started concept mapping halfway through the term. Some of us did not start until this term started. But we are concept mapping now. We are not really doing these. But this used to look like what you guys did. You guys would sit down and write one of these every week, each day for your patient. You guys will be doing concept mapping now. But this is what the care plan may look like in the chart, if they're on paper still. And then depending if they're computerized, you may or may not see a care plan written there. It depends on if your instructor has access to their computer systems. Like I've been at the Diplomat for almost a year, so I have access to their computer systems. I don't really go in and read their care plans, but I do have access to their systems. But yeah, you guys used to have to fill one of these out each day for your patient. When we look at the roles of the LPN in the nursing process. So your role as an LPN, just like my role as an RN, it varies state to state and institution to institution. So what the first basis normally goes is what the state allows you to do. So what your Nurse Practice Act for your state says you're allowed to do as an LPN. And then your institution may still say that they're not comfortable with that. Because as LPNs have been given more responsibilities, some of the nursing homes and some facilities, hospitals and nursing facilities have not felt comfortable because it's something they have not done. So they are slowly allowing LPNs to do more, but they may not. So you always have to look at what the state allows you to do and then what your facility allows you to do. Because even as, once you guys finish this program, you will be IV certified. You will also be able to, LPNs were just last year allowed, given some more responsibility with PIC lines. But depending on where you work, they may not allow you to do that. So the first thing you need to do is review your state's Nurse Practice Act. That's where you get your basis of what you're allowed to do. And then once you go through orientation for where you're going to work, you'll know what that facility allows you to do. The facility cannot allow you to do more than the Nurse Practice Act. It can take away responsibilities if they are not comfortable with it. And what I've really noticed when that comes down to it is, depending on how many registered nurses they have on site at all times, if they have one on each floor working with the LPN, sometimes they are a little more comfortable allowing LPNs to work more into their role. If they only have one in the building every 24 hours, some facilities are not very comfortable. The LPN can always provide direct bedside nursing care, observe, prioritize, intervene, and evaluate care given. When you also look at what you guys can do, what your roles and responsibilities are, like I always mention the VA. The VA is a federal government agency, obviously. So when you look at what an RN or an LPN or even an advanced practice nurse can do at the VA, it differs from what they can do at other facilities. Because with it being federal and with nurses at those facilities being able to transfer from state to state, you normally end up being able to do what is the least responsibility of all the states. They normally do not allow people to work to their fullest, depending on what state you work in. Because since you could go to another state, they have their regulations are overall for all their facilities. So what I can do here in Ohio may not be what I can do at the VA, because if I went to Pennsylvania, I may not be able to do the same thing. So they normally go with the least amount of responsibility for the states, and that becomes their policies. So that's where you're kind of looking at institutions. So when we're looking at the LPN in assessment, LPNs are observing and reporting significant data changes to the charge nurse or physician. During the diagnosis process, they are assisting with the determination of the accuracy of the nursing diagnosis. So you may be assisting the RN who has the primary responsibility of writing it with your data collection and clustering, so you come up with the best nursing diagnosis. When we're looking at outcome identification and planning, the LPN can assist with priority assessing, can suggest interventions, can assist with the development of realistic patient-centered outcomes. During implementation, they carry out physician orders and nursing orders. And you want to evaluate the effectiveness of those activities, those interventions with your patient. So if you're doing the intervention, you are the best person to know if it was effective or not. You doing the intervention and RN coming back an hour later, unless it's a pain med, may not be the most effective. So how do I know how well, feeding went or turning went if it's an hour later? When we're looking at evaluation, we're looking at the assisting with the reevaluation of your patient's health state after nursing interventions were put into place, and the suggestion of alternative nursing interventions when necessary. So question, I feel like I can't catch my breath. And an example of effective data, objective data, subjective data, or evaluation data. Subjective. Remember, subjective is something that the patient tells you. Now, if you were walking with this patient and they were becoming short of breath, what kind of data would that be? Objective, because you are seeing them become short of breath. Blood pressure of 110/70 at 8 p.m. is most accurately described as an example of objective data, subjective data, planning data, or reassessment data.
Objective.
Reassessment is not a kind of data. The only two types of data you have are subjective and objective. It's objective because that's something that you can measure. You put a blood pressure cuff on them and hopefully a stethoscope in your ear and not use the nurse on a stick or a Dynamac to figure out that blood pressure. Hopefully, Ms. Turner has taught you well and you guys all, put your stethoscope in and listen for a blood pressure. A nurse is assigned to care for 4 clients. In planning client rounds, which client would the nurse collect data on first? 1, a client receiving oxygen via nasal cannula who had difficulty breathing during the previous shift. 2, a post-operative client preparing for discharge. 3, a client scheduled for a chest x-ray. Or 4, the client requiring daily dressing changes. 1. Why are we checking on patient 1 first?
Most severe.
Which is what need on Maslow's hierarchy? Physiological. This is a basic need. Remember, if you are not breathing, nothing else matters. Our patient waiting to go home can wait. Question number 4, which of the following represents a well-written outcome statement? We have number 1, it says the nurse will assess vital signs every day. Number 2 says the resident will observe safety guidelines while smoking. Number 3 says the resident will take part in 1 daily activity for the next 90 days. And number 4 says the nurse will monitor O2 saturations to maintain greater than 90%. So I hear 3 and 4. When we are looking at outcome statements, what are we looking for? The patient. So 4, does 4 say anything about the patient? No. The 4 would be a nursing intervention. Number 1 would be a nursing intervention. So we have 2 and 3 left. Which one has all the components of an outcome statement?
3.
3. We have the resident, we have an activity, which is one activity daily, and we have a time frame for the next 90 days. Number 2 is missing what? A time frame. Okay. We're going to go over week 3 review, you guys. Anyone need a week 3 review that came in late? Did you guys in the front row sign in? Pass it that way when you finish.
Oh my god, I didn't even remember.
Oh my god, get one too.
Yeah, I don't think I went to sleep until like 12.
Do we what?
That's why I ate that sandwich. I didn't want
Okay, you guys, please remember for Wednesday,